Hey, it looks like the technology is working. You know what that means? It's 4 o'clock here in the Rocky Mountains, which means 6 o'clock on the East Coast, 3 o'clock on the rainy West Coast, and there is only one place that you need to be right now. And that is Fertility with Fink and Friends. Right here, I am Dr. Randy Fink. I'm Fink, you were friends. I'm the clinical director of IVF services here at CNY Fertility in Colorado Springs, and it is a lovely, albeit somewhat cloudy day here in Colorado with a temperature of 55 degrees right now. What's it like in your world? I think it's raining on the West Coast. Gosh, I saw all my friends in Florida got really hammered by some major thunderstorm activity yesterday, but there is no better place for you to be right now than here with me. So glad to have you with us. Let's see what we've got. We've got some different feeds here. First up on the CNY Instagram side, Krista Whitley. Hello, you get a special wave. Thanks for being number one there. We've got Sarah and Macro Mama. We've got lovely Onyx. Faith Waring, nice to see you. Jenny, Hunter, Baby Wishes, Melissa, Baby Girl. What else? We've got Jessica, we've got Hannah, we've got Chad. Good to see everybody here over on the, we've got a Facebook stream, pardon me, and a YouTube right here in the middle. And over on this side, a very special hello to all my friends on my own Instagram feed, which is coming from right here. Special greetings to Zenaida in Miami, who is having a very special birthday in the next couple of days. Isn't that right? My friend Nancy Bernard is here with us as well. What a pleasure to see you. First up over here was Zenaida. You too get a special wave. Pretty Binky is here. We've got Rochelle, Ceciliana, Melissa, my good friend Brandis, our wonderful nurse practitioner here, and a special, very special hello, of course, to Mom and Dad joining me from Southern Alabama, from LA, Lower Alabama. Mobile, Alabama. Thank you for being here with me today. I'm still trying to get over this. It seems like it's sort of the 100-year cold, at least the 100-day cold. It's been going on for quite some time, and at least I sound sultry, and that counts for something. But tired of cough, sick and tired of being sick and tired. You know what I'm saying? And if you were here with us last week, we talked a little bit about, what a design flaw it is in the human body to be subject to these respiratory illnesses, and how we really, in all these years and in 100 years of modern medicine, that we really haven't come up with better solutions to being able to fight off basically the common cold and these very common illnesses that get us. It's more and more every day, different kinds of viruses and things like cancer that we're learning how to battle. But the mundane, the routine, the stuff that just makes us miserable, I don't know that it's really changed all that much in all these years. But happy to see everybody here today. I wanted to start out, I've had talked to a bunch of people this week who have been going through all different kinds of strife, and that's things like overt miscarriages or failed, unsuccessful cycles, trying hard to get eggs, to make embryos, and being unsuccessful with that, or making eggs but having them not fertilize, or having embryos disintegrate or not able to grow. Things like biochemical pregnancies, which is, of course, where when we think of a miscarriage, we think about a known intrauterine pregnancy and how that grows. And we can do an ultrasound and actually look and see the heartbeat when we have a heartbeat, but then that heartbeat stops and that pregnancy passes. That's what we call a miscarriage. A biochemical pregnancy happens when the pregnancy test or the hormone level is positive, but we don't yet see anything inside the uterine cavity. The hormone level starts to go up until it realizes that something is not going right, and then that level starts to drop off. That is almost always known as a genetic issue. It is sort of a half a step in the right direction, I tell folks, because at least we know the brain is talking and the uterus is listening, and you're able to to implant a pregnancy, but that pregnancy just isn't growing. Nevertheless, it's a very frustrating thing to have happen. And so lots of folks that I know personally and who have been through hard times, even before, are now pardon me, in this last week, dealing with their own set of strife, and I find that it really helps for us all to be together here. And I was giving that some thought about how, well, we may not be able to fight off the common cold very well, but we are a fairly resilient species emotionally. And if you think about it, imagine, if you will, all the things that have happened to you in your lives, things that are, maybe, call them things that are embarrassing or humiliating, bad memories, things that have happened that you wish never did, the kinds of things that haunt you, the kinds of things that you wake up or that you have a hard time falling asleep to at night when you think about all those difficulties that we face as humans, because life is not an easy place to live. And how we somehow or another, most of the time, manage to persevere. And even when times feel hopeless, even when you feel like giving up, something in you allows you to keep going. And I don't know what that is. Maybe it's faith in something bigger out there. I had cause to think about a man that I met a number of years ago. In fact, it's been a lot of years ago. A guy by the name of Charlie Plum is his name, and he's still around. I believe he lives in California now. Charlie Plum is now a motivational speaker. Charlie Plum was a pilot in the Vietnam era. He flew an F-4 Phantom jet. He had flown about 74 sorties over Vietnam from an aircraft carrier in the Gulf of Tonkin. And on his last mission, the mission before he was to rotate back home, he was shot down by a missile over enemy territory. And he was captured and kept as a prisoner of war for, I believe, about forgive me, I don't remember the amount of time, but for a number of years. He was a resident of the infamous Hanoi Hilton, where he was tortured and abused, and all kinds of terrible things happened. He went on in his life he wrote a book that's called "I'm No Hero," it's a very telling book. He went on to become a motivational speaker, and I've heard him speak before. It is really very wonderful experience. So much so that now that I think about it, I did look him up again and found that he's still around. But I should have listened to some of. I'm sure there's some YouTube video and stuff on him now. But one of the most telling things I remember in his book, anyway, was something that I learned long ago. It was a poem that is entitled Invictus. Invictus. And Invictus in Latin means unconquerable. And maybe you learned this back in high school, but it's still something that kind of resonates with me. So I thought I would share it with you. It seems it's heavy. And maybe it's too heavy for the fertility world, but it's something that's meaningful, nevertheless. And William Ernest Henley said, "Out of the night that covers me, black as the pit from pole to pole, I thank whatever gods may be for my unconquerable soul. In the fell clutch of circumstance, I've neither winced nor cried aloud under the bludgeonings of chance. My head is bloodied, but unbowed. Beyond this place of wrath and tears looms but the horror of the shade, and yet the menace of all these years finds and shall find me unafraid. It matters not how straight the gate, how charged with punishment the scroll. I am the master of my fate. I am the captain of my soul. So I don't know. That's Fink's feel good for the week, and I see over here on my Instagram thousands of people are just dropping off. So maybe it didn't resonate with you, but gosh, it's something that always resonates with me. And so Invictus, William Ernest Henley, and the words of Charlie Plumb that I heard direct from his mouth back sometime in the 1980s still stick with me today. We are a resilient species, and despite the things that happen to us day by day that challenge us, we will persevere. So that said, let's see now, 11 minutes into the program, if we can get into some questions and answers. And hello to all the Facebook folks who have shown up. Hi to Sefale and to Tamara. How soon after delivering a baby and nursing is it recommended or safe to prepare my body for an FET? Well, first of all, you raise a good point there about nursing. We do not recommend that you do an embryo transfer or even try to get pregnant if you are still breastfeeding. Why is that? Well, there's a couple of reasons. So even as a general obstetrician, we would tell you that there are challenges to the environment inside the uterus when you are trying to maintain a pregnancy nutritionally on the inside, but still trying to maintain a baby on the outside by breastfeeding. By the same token, there are hormonal abnormalities and abnormalities in the uterine lining that can make the implantation of a new pregnancy, particularly if you're doing one through IVF with an embryo, the environment can be less than hospitable. So we do want you to be done with breastfeeding. Highly, highly recommended. Generally, we say 6 to 9 months after delivery is an okay time to consider maybe doing another embryo transfer. If you had a C-section, then I usually recommend a full year. The reason for waiting is because it is said that the one preventable risk factor for severe preterm birth is actually that short interconceptual interval. So if we can spread that out a little bit, we do better both with getting pregnant and with staying pregnant. Scott, looks like Scott and Mel Wormwood, good evening. Just wanted to say how my husband and I appreciate you. Oh, thank you very kindly. You, Dr. Kiltz, and all of CNY Fertility, we are on day 3 after transfer. Couldn't have gotten this far without Team CNY. Well, thank you so much, Scott and Mel, and all the best to you guys. And another nice gram here from Holly. Thank you. Dr. Fink, thank you for our twin girls. Forever grateful. Gosh, I love to hear that. And Holly, man, I would love to have a picture of your twin girls to put up on our wall. Looks like Tamika asks, if I have lipo done, how long should I wait to do another FET? There's no specific guidance on that. Liposuction can have an effect on some fluid dynamics and some things like kidney function and so forth. But most of the time, by the time you get pregnant again, or rather by the time you get a period again next month, you should be, relatively speaking, ready to proceed with an FET. To Hiskeen Loving Me Keith, hello from Florida and hello to you. Here is Shannon as well. I did a fresh transfer on January 20th and it worked. Woohoo! First ultrasound is on Friday, having some painful cramps every now and then, not surprising. Maybe 10 seconds long, 2 to 3 times a day. Is that a bad thing? And how common is there no heartbeat? I'm scared that this one won't be viable. Well, there is actually, from a positive standpoint, there is what we know as a miscarriage calculator. And if you Google miscarriage calculator, you can put in your gestational age, and it doesn't tell you about how what the chances are that you're going to miscarry. It presents it in a very positive way, and that is, well, what are the chances? What are the odds? How great are the odds that you have an ongoing pregnancy? And so that's a very nice thing. It's a useful, kind of put in the number there. Typically, by a little over 6 weeks, we should be seeing a heartbeat. If we're not seeing a heartbeat at a little over 6 weeks, we start to think that perhaps something is not going right. Usually, it's actually about 5 weeks and 5 days. Maybe the day before, you can sometimes see a heartbeat. At the 6 week mark, sometimes it may be a little harder to see. It's also a little bit slower. It begins looking a little slow, sometimes around 90 or 100, maybe even 110. But by about 6.5 weeks, we should see a normal heartbeat in the 120-ish kind of range. So usually we tend to look for heartbeats a little after 6 weeks. But if you're around 6 weeks, odds are you should see a little bit of a flicker in there. And congratulations, Shannon. That is really fantastic news. As far as the cramping goes, the uterus is constantly growing. The uterus is moving. It's constantly kind of moving up like this. So it's pretty normal that you'll have some cramping. And not only that, to be perfectly honest with you, inside the abdominal cavity, there is a lot more bowel than there is anything else. There's a lot more bowel than there is uterus. There's a lot more bowel than there is ovary, a lot more bowel than there is anything else. And the bowel is also constantly moving, constantly digesting, trying to push material and gas through. And so it's very common to feel that. And the hormones do change the motility, the way the bowel works. And so not uncommon that you may feel that as well, more so even in early pregnancy than before you're pregnant. And that can make people very nervous for sure. Okay, Galaviz, it looks like M. Galaviz 21. Sex around the time of FET. What are the restrictions, if any? Well, it depends on who you ask. So there are some specialists who will tell you absolutely not, do not have sex around the time of a frozen embryo transfer, because we don't want there to be any confusion as to what's going on on the inside. So let me give you an example. We had a patient who transferred a male euploid embryo, ended up with a positive pregnancy test, but with a female baby that ended up having a genetic abnormality. As it turns out, what happened was because they had intercourse around the time of their embryo transfer. And so in fact, it was a natural cycle. So it was dealing with ovulation. She ovulated on her own. That sperm went in there, fertilized the egg. And that's the one that implanted. So can it happen? Yes, it absolutely can happen. Now, if you're doing a medicated cycle, then we are inhibiting your ovulation. So you will not be getting pregnant from sperm meeting egg, because you're not going to be releasing an egg. So in that scenario, really, honestly, it truly shouldn't matter at all. But if you're doing a natural cycle or a modified natural cycle, I think it's better not to have intercourse right then, because the embryo that's going to be going in really is the one that we want to take priority, because you invested a lot into making that environment perfect for the embryo that you're going to be putting in through your FET. Now, that said, someone else could make a very convincing argument that, well, who cares how it happens? The goal is to get pregnant. And if you're going to get pregnant, whether it happens to be that that's the time it's going to work naturally, or whether it's through your frozen embryo, at least you get pregnant. So, hard to give you a good, clear answer there. But if it is a medicated cycle, you don't have to worry about a spontaneous pregnancy. Chef Blackney is here. California rain. It never rains in California, but Chef, don't they warn you? Lovely Onyx says, what can I do for acid reflux caused by the progesterone? And it causes phlegm in my sinuses. Not the first time I've heard that. So Actually, you can take Mucinex. Mucinex is said on many levels to actually improve pregnancy outcomes. So there is no harm to using Mucinex. But as far as acid reflux, um, if you're using one of our immune protocols, you'll probably be on some Zantac or Pepcid, along with some antihistamine. That will help. You can use Maalox, Mylanta. You should elevate the head of your bed by using a couple of extra pillows. That can help. But what progesterone also does is it can slow down some of the movement of the esophagus, which is connecting the mouth to the stomach. It can slow down stomach emptying time and therefore can cause some of the acid that's in the stomach to work its way um, back up here. Let's take a look at my Instagram side here. Well, hello to New York baby DJ. Nice to see you. Blonde Portuguese princess is 5 weeks pregnant. Congratulations. Gosh, Michelle, that is fantastic. And I'm so happy to hear it. Hello to Carly Tercios. Good afternoon. Siciliana Melissa says, how long after Orlissa for endometriosis suppression should you wait to do an embryo transfer? I do natural FETs. Will Orlissa mess with the lining? Is natural or modified FET still an option? So if you have endometriosis, we know that that endometriosis confuses the way the brain is talking to the uterus, and it can decrease the success rate of an embryo transfer. So we recommend that you do some suppression with medication of that endometriosis. And so, Melissa, that's what you're doing with your Orlissa. 60 days of medicated suppression should be sufficient to do the job. And then we recommend that you go directly into an embryo transfer cycle just after that. So 60 days and then directly into a cycle. What kind of cycle should you do? I would recommend a modified natural. You do not have to go into a medicated cycle. In fact, I honestly prefer that you don't. I prefer the modified natural cycle. But a fully natural cycle where we're expecting you to ovulate on your own just may not work the way we want it to. Because you've been on suppression, what that medication has been doing is partially turning off the way your brain sends out the hormones, you know? And if that's the case, then, well, that next cycle, if you rely on it to be purely natural, may just not work the way that you want for it to. A modified natural frozen embryo transfer cycle is where we give you some ovulation induction through the medication of typically letrozole. Letrozole for 5 days will get your ovary to produce an egg in a predictable fashion to allow that egg to grow. And as it grows, the little cells that surround the egg in the ovary, which are known as granulosa cells, that's where your natural estrogen comes from. So your estrogen will thicken up your lining like it does every other month that you're not trying to get pregnant, grows up that lining. And then when we see that that follicle is of a sufficient size, we can trigger the ovulation. Triggering you gets put some control back in your hands so that you'll be able to have some say logistically over when you're going to have your embryo transfer. We start you on some vaginal progesterone so you don't have to do the progesterone in oil shot, which is our least favorite intervention in all of the infertility world. So no shot, vaginal progesterone only. You get your transfer and God willing, you are pregnant. So that's a modified natural, and that's what I would do after endometriosis suppression. The very next month, the month just after stopping your 60 days of suppression, is when that suppression will have its best effect, and your odds are said to be at their highest. Oh, hi to Indy and Tiffany, and Amanda Marie says, would you recommend Zymote with donor sperm? The donor is 36 years old. Well, so Zymot or Zymote, I believe is the correct pronunciation. I always call it Zymot, but I'm pretty sure I'm wrong. Is a method of sperm preparation in the lab. It's here at CNY. It's an add-on. It's a $200 add-on. So people say, should I be using it? Well, to be honest with you, it's a $200 add-on. It's not a $2,000 add-on, and there are many clinics that dramatically increase, raise the price of that Zymot, sometimes even to like $2,000. Basically, what it is a little cartridge, and they take the sperm, and and it requires two things. It requires adequate motility of the sperm, meaning to say there's enough sperm that are swimming. And it requires a sperm count of at least 2 million. They take the sperm, put it in one side of the little cartridge, and it's like there's a little obstacle course on the inside, requiring the sperm to go through this obstacle course. And the sperm that come out the other end are said to be the best sperm. These are the ones that have the lowest amount of what we'll call DNA fragmentation, that the genetic material in the sperm is likely or is believed to be the most normal given the situation. So, is there a harm to doing it? No, it actually has been shown to decrease miscarriages, but it also decreases. Now, this is a hard one to stomach. Listen to this. It decreases pregnancies. Well, wait a minute, hold on. I thought the whole goal here was to increase pregnancies. Well, it's decreasing pregnancies because it's decreasing miscarriages. So, really, what it's doing there is that it's decreasing the number of genetically abnormal pregnancies that will, in fact, implant. So, it's not a bad thing. Should you use it with donor sperm? There's no harm to using it with donor sperm, Amanda, but I think the best use of Zymote is in a couple that have what we'll know as unexplained infertility. So we don't know why they're not getting pregnant. They're just not getting pregnant. So therefore, you're moving on into IVF, which has a fairly high probability of getting you pregnant. Well, that's the best scenario, I believe, for Zymote. But really, in any scenario, as long as there's a sufficient sperm count, it should decrease the number of miscarriages occurring in the pregnancies that result. So hopefully that is a helpful thing. Oh, I stuck my hand in front of the camera. Sorry about that. Hi to Nina Buena. Rashmi says, so happy to see you every Tuesday. Thank you. Could having a cold during ovulation affect pregnancy rate? I had injectables and an IUI this cycle. Well, it's a good question, and I'm not sure that there's really a great answer to it, except that, well, we do know that a cold virus it creates an inflammatory effect in the body. A cold is a normal part of the human condition. It's not something that, as we were talking about before, we can't prevent it. We can't stop it, but and it's sort of ubiquitous. It's everywhere you look, somebody is getting a cold. But do people get pregnant when they have a cold? Yes, absolutely, they do. Now, we do know from some experience with COVID-19 that having COVID can decrease egg quality and, in fact, available number of eggs for recruitment at the beginning of a cycle. So for that reason, 60 to 90 days, we typically recommend, if you can, to wait after COVID in order to really get the best outcomes. Does the same thing happen with a common cold? Well, it's a virus, and some of those cold viruses are coronaviruses as well. Does it make a difference? I don't think anybody can really say, because I don't know that it's explicitly been studied. But given that people do have colds at home and get pregnant all the time, or in the back seats of their car or wherever, I'd say it's probably okay. Let's see what else. Back to the Portuguese princess here. My husband had a great count in motility. Well, we still chose to use the Zymote, and we ended up with most of our DG. So yeah, Zymote can be used really in any circumstance. Can you use Zymote with a fresh transfer? Yeah, so Zymote is for making embryos. So you've done your egg retrieval, you've provided the sperm, whether it's fresh or frozen sperm, and then those eggs are fertilized. So basically, it's helping the embryologist to select the sperm that they are going to pick to do the fertilization with, the ICSI with. So yes, and then that creates an embryo, and you can either do a fresh or a frozen transfer. Ackman's Adventure says, my husband has low morphology and motility. And I would say as long as, certainly in the case of low morphology, that's probably a good reason to use the Zymo, because you're going to be able to select a better sperm there, as long as there is a minimum amount of motility. That is to say that there are enough sperm swimming that they're going to be able to swim through that little obstacle course. I think that's a great indication there. Back over to our friends on the Facebook side. Let's see, Tori here says, my cycle days also range anywhere from 29 to 37 days. Is that normal? And if not, would it cause problems when doing IVF? Also, I'm taking all the molecular fertility vitamins that are recommended. Should I be taking what is recommended on the bottle? Some say 6 pills per day. Anything else I should be taking besides these vitamins? Tori, that is a couple of really good questions there. So let's see if we can answer. A normal menstrual cycle is really anywhere from about 21 to 35 days. People have a lot of variation in there. And in fact, one of the more common complaints I would hear as a general gynecologist would be people would come to me and say, well, my period is always very exact. It is always exactly, I can set my watch by my period because I have it at exactly the same minute of the same hour of the same day every single month. So if I am 20 minutes late, then I know something is wrong, and we need to, I need to attend to this. Maybe. Okay. Is there something wrong with you if you have some variation in the menstrual cycle? Absolutely not, because there are so many things that can cause variation in the menstrual cycle. Things like stress, illness, your diet, your weight, how much alcohol you've consumed, how much exercise you've been doing. Even down to how much breast stimulation potentially have you had. All that stuff can change your cycle. Excuse me. So variation is normal, and anywhere between 21 and 35 days is normal. Now, you say that you're kind of between 29 and 37 days. I would say that is okay. The issue that you probably have conceiving naturally, or one of the issues, may just be kind of the timing of getting the right sperm together with the right egg. So if you can't get the right sperm together with the right egg, you ain't going to get pregnant. And if your ovulation is unclear, and if it's not consistent and the timing is always off, then your ability to get the sperm to the egg may prove challenging. Now, in the IVF realm, that doesn't matter at all, because we're controlling all of that. We're causing the eggs to grow, and we are triggering the ovulation so that we can come retrieve those eggs. So that shouldn't be an issue with IVF. Now, as far as, I would follow the directions on the molecular fertility vitamins. I am actually working on a little book at the moment that will be a very, very low cost ebook that comes with a discount on getting certain vitamins, that really outlines what specifically the nutritional supplement protocols are for the fertility world, whether you're trying on your own, whether you're doing IUIs, whether you're doing IVF, whether you're doing an embryo transfer, and whether you have PCOS, whether you're female, whether you're male. So keep your eyes open for that. And to that fact, I see down here, Rashmi has asked, what's the importance of the NAC supplements in recurrent miscarriage cases? NAC stands for N-acetylcysteine, and it functions, you may have heard of that medication before, because it is actually the antidote medication in higher doses to Tylenol toxicity. Did you know that Tylenol is probably the most dangerous drug on the market? likely more so even than some opiates. Because it's so easily available, you can get it in any drugstore off the shelf, but too much Tylenol is extremely damaging on the liver. So, if you have had a Tylenol overdose, the medication that you're treated with is N-acetylcysteine or NAC. NAC is a recommended supplement for folks with recurrent pregnancy loss, and it has to do with its effect as an antioxidant. Yes, I do recommend it in that situation. We were talking here with the folks on the Facebook. Lori is here with us today. Would you change anything with a protocol after a failed euploid transfer if it worked in June of last year? So, in most cases, there's some talk, there's a difference between the medicated cycle versus a natural cycle. Which is better? Gosh, the the medicated cycles have been around since IVF was invented. They've been doing them for 40 plus years, and I think still, by and large, 85% or so of the transfer cycles in the United States are medicated. Um, it works. We can control every variable. And if it worked for you before, you'd be hard pressed to say that you should be changing it. I don't think that there is, as opposed to a natural or modified natural cycle, which is at least as good, and some studies show even better, that there may be a lower rate of miscarriage. I wouldn't say there's necessarily a compelling reason there, Lori. I think, if it worked for you before, if you got pregnant with it, there is no harm to doing it that way. Now, just because one euploid embryo didn't implant doesn't mean that something is wrong with you or that you need to be changing the protocol. And this is a question that we get here really every day when we talk to folks on the phone. They say, I didn't get pregnant with my transfer, so what are you going to change with my next cycle? Well, the truth of the matter is that the problem has nothing to do with the protocol. It is almost always an issue that pertains to the embryo itself. And by the time you're doing that transfer, the embryo is already made. So we're not really going to be able to change too much. Can you switch from a medicated to a natural cycle? Yes. Can you increase or decrease what I call the icing on your cake, which is those medications that we use with the immune protocols? Yeah, sure you can. Are those things really going to make a difference? In most cases, probably not. It's going to end up to be, is it a good embryo? Is it a normal embryo? Or is it not a normal embryo? Because in most scenarios, it's not a mom problem. It's not a uterus issue. It's an issue of something going on either genetically or metabolically in the embryo itself. Do you need to have a period to start trigger medications? Can you start after day 35, 36? Well, pardon me again. When you say trigger medications, usually a trigger means that we are telling the ovaries to release an egg. And so that requires you to be at a particular stage of your cycle, that you have to have a mature egg there in order to be able to ovulate. Maybe what you mean by starting trigger medications is starting stimulation medications. And technically speaking, stimulation medications can really be started anytime. We usually start them at the beginning of a cycle, just sort of for ease of use. If you start sort of in the middle of a cycle, you run the risk of getting, some fewer eggs. But there are situations where, let's say someone has breast cancer, and we have to start because they have a hard stop on when they are going to start their chemotherapy. So we have to start their therapy ASAP in order to get those eggs. We really can start that kind of stimulation at any time. Lindsay is here. Can't wait to meet you on Monday the 12th. Outstanding, Lindsay. Me too. My husband loves this saying, I am the captain of my soul. Oh, good. Thank you for listening to my poem a little earlier. Thank you very much. He is the captain of his soul. Imani is here for failed FETs. Just received the ERA results that I am pre-receptive. Need 24 more hours of progesterone. Only one embryo left is a low-level mosaic. Should we use the mosaic for the fifth FET or do a new retrieval? So let's talk about that mosaic embryo. There's nothing wrong with a mosaic embryo. What it really means. So first of all, when we do PGT testing, we're really testing from the portion of the embryo that comes from the placenta. So we're not testing the embryo itself. We're testing the portion that's known as the trophectoderm. It's the outside part of the embryo. It is possible to have a little bit of an abnormality in the placenta that does not exist in the baby parts themselves. A mosaic means basically, so we've got two sets of chromosomes, we're 46, I'm a 46XY, right? So XY is the male chromosome. We've got 46 or 23 pairs of chromosomes. Well, basically what it means is that in one set of those chromosomes, something isn't quite right. Now, what we know from these mosaic embryos is that if they implant, if they give you that positive pregnancy test, there's nearly a 100% probability that they are as normal a baby as you would get with your euploid embryo. So you don't have to fear a mosaic. In fact, what it means is that, well, okay, so we know that if you have a euploid or a chromosomally normal embryo, that embryo is going to give you about a 65% probability of being able to get pregnant. Right? If we have a blastocyst that is untested, that you grew it out to, let's say, day 5, but you didn't do the testing on it, that embryo has about a 30% probability of being able to get you pregnant. A mosaic gives you roughly about a 40 to a 45% chance of being able to get pregnant. Again, with nearly a 100% probability of having a normal baby if it sticks. So there's a slightly higher risk of miscarriage, but it is not a bad embryo. It is not a throwaway embryo. It is not an embryo that is believed to going to cause you to have, a baby with some terrible genetic problem or a birth defect. So I think you can feel good about transferring a mosaic embryo. Really, in your case, Imani, there you're talking about, well, do we do another retrieval? I think really the question there is, how many kids would you like to have? Because if you do that transfer and it sticks, now that we know that you've got a receptivity issue, if it sticks and you get pregnant, realistically, it's going to be another probably year and a half before you can do another egg retrieval, in case you wanted to have more kids down the line. Well, depending on how old you are, a year and a half can make a big difference with egg quality. If you would be happy with just one more child, and if that embryo gave you that child and you're done, I would say by all means, go ahead and do the embryo transfer, because now you found a little difference in timing that you're going to make up for, and you're going to get that embryo in, and hopefully you get pregnant, and then there your problem is solved. So really, it just kind of depends on age and how many other kids you want. If you're thinking, gosh, we really want to have 4 more kids, the younger you are when we get those eggs from you, the better off we're going to be, the greater the probability that we're going to get ourselves a normal embryo. So given that scenario, you want to do more retrievals. You want to maximize the number of eggs so that you can maximize the number of embryos. Ashley asks, can letrozole mimic PCOS? I started letrozole and now my doctor thinks I have PCOS. Well, that's interesting because so I almost lost a signal there. Does letrozole mimic PCOS? Well, letrozole lowers your estrogen rate. I'm going to say the short answer to that question is no. Not so much. Tori is here. Tori says, Done 3 rounds of IUI that did not take, and moving on to IVF with your clinic in Colorado. Excited to get started. My AMH is 5.2. Is that normal for a 29-year-old? That's a very good AMH. That tells me that your ovaries are likely to respond very well to the stimulation medication. Awesome. Is it a little high? Well, I mean, when it's above about a 5, we consider that kind of consistent with the way polycystic ovaries will respond, which means the ovaries just pay really good attention to the medication. So I think you'll probably get a lot of eggs there. My cycle days range anywhere from 29 to 37. Is that normal? Like we said before. Yup, I think so. No problems with IVF. And I think we got to those other questions before. Hiskeen asks, can you do IVF with blocked tubes? Yep, you would do IVF because of blocked tubes. So yes, indeed. Let's see what we got going on here on the CNY Instagram side. How long after egg retrieval can frozen embryo transfer happen? So you can, and that comes from Faith. Hi, Faith. You can do that the very next cycle. All right. So you do your retrieval. 10 days or so later, you're going to get a period. You can start an embryo transfer cycle in that very next one. Hi to Hunter. Hi. Ricky Marcus, again with the chef. What else we got going on here? The weather is bad in the high desert of California. Bad flooding and sinkholes, and it's about 35 degrees. Gosh, yeah, it's bad times according to the news there. Connie is in Arizona. I don't think the weather's bad in Arizona right now. Kayleen is here with us today and says, I have a gene called a 4G, 5G allele. Okay, which is a blood clotting disorder. I have had 3 miscarriages. What can I do to prevent my next one? One of the symptoms of having the gene is recurrent pregnancy loss. So recurrent pregnancy loss is an identifiable medical condition. And one of the evaluations we do for that is a panel of blood tests that look to see if there's something in your blood that's causing the clots to form in the small blood vessels that supply the uterus and the placenta, because that is one reason folks can have a recurring pregnancy losses. Usually the treatment for that is very straightforward. The problem with it is identifying who has the issue, because there are lots of folks who have recurrent miscarriages that don't ask the doctor. They just kind of keep trying, or they may ask their OB and not get the correct response about, well, how am I supposed to evaluate that? And that is with what is known as a thrombophilia panel. Thrombo means clot, philia means likes to. So there's something in your body that makes you like to clot. Kayleen, the way we would treat that is with a blood thinner known as Lovenox. In most cases, we would use Lovenox. There are some that we use, can just use baby aspirin for, but generally speaking, Lovenox. And we use Lovenox kind of in many of our treatment protocols here at CNY, because there's a lot of folks who may have those kinds of blood clotting issues, but haven't been able to identify them. There's not a reason in everyone to check for those thrombophilias in folks who've never had a pregnancy loss. But in our world, we're trying to do everything we can to get folks pregnant. So in your situation, that should be very straightforward. Usually you stay on those medications until about 36 weeks of pregnancy, about a month before your due date. And you can definitely safely have a child. Hi to Sarah. Nice to see you, Sarah Burdick. I have my second baseline appointment for an FET on Friday. Yay, love CNY. You're the bomb. Thanks for saying so. It's that kind of feedback that really, keeps us going here. So thank you very, very much. Hey, it's about 11 minutes before the top of the hour, so we've got a little bit more time to try to get some questions in here. I'm doing the best I can, try to get down the list. Thanks so much for being with me here today. It means the world to spend my every Tuesday afternoon with you. So thank you so much. Evil Shenanigans says, Shenanigans, not shenanigans. Evil Shenanigans. Did a fresh transfer on January 20th, and it worked. Outstanding. Oh, you know what? I think we answered that one before. Painful cramps out every now and then. Is that bad? No, cramps are generally kind of pretty normal stuff. Um, on cloud, Neidig. My husband has a Klinefelter syndrome. That's a genetic condition. Why? So that is why we're needing to do IVF. What is the percentage that he could father a child not having the severe symptoms for it? So it really depends in that situation on the semen analysis, because in some cases, Klinefelter's can result in issues with sperm. So that would really be question number one: is what does the sperm look like? Sarah Walker says, how do we go about testing for a translocation issue? I had a trisomy 13 loss with my first transfer from a sperm anomaly, and we're both pretty young. Those types of things are generally considered to be isolated events, and it's usually an isolated event that's going to cause an autosomal trisomy, like a trisomy 13, which is a common cause of miscarriage. But what you could do to answer your question, and trisomy 13 is not a translocation. That's a different kind of genetic problem. But very simply, all you have to do is you get what's called a peripheral blood karyotype. So just like I said, I'm a 46XY. If someone draws a tube of blood out of me and looks at the chromosomes in my blood, it's going to be 46XY. Same thing you can do for you and for the sperm partner. It's called a peripheral blood karyotype. Your own doctor, really any doctor can order that and can check. That's what would show us a translocation. Translocation is another common reason that folks can have recurrent pregnancy loss or recurrent implantation failure. Certainly not a problem to do that test. Megan Downey says, my HCG is 11 after a miscarriage. I should ovulate in the next few days. Is it okay to try while still having HCG in my system? Well, the first thing I might say there, Megan, is that if there is still HCG in your system, you may not ovulate. You may need to have a negative beta before your ovary will start to develop a follicle that will grow to the point where it will be ovulated. So if you believe you're going to ovulate, yes, you certainly still can. But my question is, I wonder if you really will ovulate under that scenario. Macy Clark says 2 out of 5 of my embryos were abnormal. I want a PGT test my remaining 9. Would you consider it worth the risk of thawing and rethawing? Well, so what Macy's talking about here is that you can take some embryos and you can thaw them and biopsy them and refreeze them. And do the PGT testing. And then when you get that result back, you say, okay, these are the normal ones. So we will thaw the normal one, and that's the one that we'll do the transfer with. It's definitely better to do that testing when the embryos are fresh before you've frozen them the first time. However, can you thaw, biopsy, and refreeze? Yes, you can. But here's the risk that you run. An embryo has a little tank of gas, and that's its energy supply. And every time we do something with that embryo, like freeze it, thaw it, biopsy it, refreeze it, thaw it again, we are using some of the energy supply in that little gas tank. Eventually, that energy supply may run out. We don't know specifically when that will happen, and that may be really quite variable depending on the embryos itself. But if you have a blastocyst, and you thaw it, biopsy it, refreeze it, and then go to thaw it again, that is a riskier scenario than taking a day 3 embryo, thawing it, allowing it to grow to blast, and then biopsying it and refreezing it. So that day 3 embryo is going to have a more substantial, or really a better refillable tank of gas. So it's less risky to do that with a day 3 embryo, grow it to blast, then biopsy and refreeze, and then thaw it when you're ready, than it is to do that with a blastocyst. Now, you have 9 embryos there, if I read that correctly. And so I would think that, you're going to get some results from that. If you had one single embryo left, I think that's a much harder sell. You know what I mean? Because you're risking that embryo. With 9 embryos, some of your embryos are going to end up normal. Are you going to risk any of the embryos? You might, but are you going to risk all of the embryos? Realistically, probably not. Hope that makes sense. Let's see here. Emily Temple says, I had my retrieval with you about 2 weeks ago. Thank you. Only have one embryo, but we're going to see how it goes. Outstanding. How far ahead of time do you start an immune protocol before an FET? Well, I think the easiest way to do that, Emily, is just to start it kind of with your menstrual cycle. So whether you're doing a medicated or a natural or modified natural, you notify us on cycle day 1, and you would start doing the immune protocol meds kind of with that period. In most cases, there are some situations where we recommend that folks be on the medications for longer term, but for the general public, I would say that just kind of starting with your menstrual cycle. I got a little distracted because Jody Hoffman joined, and Jody Hoffman is one of our, and so did Maria Alvaro, who, gosh, what can I say? Wow, Maria, thank you for being here. Jody, not so much, but Jody's one of our wonderful CNY phone nurses who used to be our nurse manager here in the Colorado office, but she moved away, left us in the dust, and so I really have nothing left to say to you, Jody. You've hurt me. How you've hurt me. All right. Carolyn says they have me doing both the progesterone in oil shot and the vaginal progesterone. Why is that? Well, so the progesterone in oil shot you're using because you are on a medicated cycle. So you have to use progesterone because you don't have progesterone from anyplace else. When you add the vaginal progesterone, it has a local effect just in the uterine lining. So it just helps things a little bit. If you're doing a medicated cycle and you don't want to use the PIO, the progesterone in oil, I would tell you don't do a medicated cycle because in all probability, it's not going to work. The vaginal progesterone alone in a medicated cycle is not sufficient in terms of the amount of progesterone to be able to support a pregnancy. We use them together because they work, sort of hand in hand to help that pregnancy grow. If the shot is something that you can't do for whatever reason, then do a natural or a modified natural cycle. It hurts me when I see folks doing a medicated cycle, but they say, I refuse to use the PIO because I don't like shots and they hurt. In general, it doesn't work very well for getting people pregnant in that kind of medicated cycle. Let's see here. Carolyn says, I feel like the $200 add-on is very affordable. I guess we're talking about the Zymont. I decided to do it for this reason. Felt it gave me a better chance for fertilization, and I do agree. I think it's it's a very modestly priced add-on that really may make some difference. Linda's asking, do I have to do genetic testing? Nope, absolutely not. Genetic testing is purely voluntary, and in many cases, not at all recommended. Let's see here. Taylor, Nicole, looks like I see Taylor. Do you recommend transferring 2 healthy embryos for a first time transfer? Never been pregnant. This would be the first time. And I would say probably not. There are guidelines that we follow from the American Society for Reproductive Medicine that tell us what we should be doing as far as recommendations for how many embryos to transfer. Transferring more than 1 embryo does not improve the live birth rate. In fact, it dramatically increases the risk of a multiple gestation and therefore bad things like severe preterm labor, prolonged NICU stays, cerebral palsy, autism, things that we would rather be able to avoid. So in a first transfer, depending on your age, and I'd say if you're under, I think the age is about 40, we're always going to tell you that one embryo, especially a blastocyst that you have there, is what is the recommendation. Let's see if I've got time for one more over here. And it looks like that's going to be Kristen Martin. Letrozole days 3 through 7 or 5 through 9 for a better egg quality. We do 3 through 7. So you want to start recruiting those eggs as early as possible in the cycle. So I usually start letrozole on day 3. Gosh, folks, guess what time it is? Top of the hour. So that means we are done with Fink and Friends for another Tuesday. But in my sincere hopes that I will be able to see you again next week. If you didn't hear the poem in the beginning about what resilient species we are, I am the master. I am the master of my fate. I am the captain of my soul. Lead forward with kindness, with love, and most of all, every new day with hope. Because like the sign says behind me there, fertility problems are not the novel of your life. They are not your book. They are purely just a chapter. And what we're here to do is to help you to rewrite it. So until next time, God bless. Thanks so much for being here. And good night.